Hello, my name is Khadija and I'm presenting on early intervention and risk prediction for preschool children who stutter. I'll define the emerging issues, summarize contemporary evidence about which children are at a higher risk of assistance, explain how intervention plans should be adapted, and outline the scope and responsibilities of a speech pathologist in this context. Why this matters. Childhood onset fluency disorder or childhood stuttering affects around 5 to 11% of preschoolers, typically beginning at about 33 months. While 75 to 80% recover naturally within 15 months of onset, recovery rates fall to 50 to 60% by the age of 5. This creates a challenge in identifying which children will persist and may require therapy. Delaying interventions for children at a higher risk may allow persistent speech habits to develop, making therapy more challenging. Children who continue to stutter are also at risk of developing negative communication attitudes and psychological distress, which may reduce therapy effectiveness. By age 7, persistent stuttering is likely to become chronic with long term social, academic, and vocational impacts. Several risk factors help predict stuttering persistence in preschoolers. Family history is the strongest factor. Research has shown children are more likely to persist if relatives also stuttered and did not recover, whereas a family history of recovery increases the likelihood that the child will also remit stuttering. Sex is another predictor. Boys are more likely to continue stuttering, with the male to female ratio increasing from 2 to 1 in preschoolers to 4 to 1 or higher in adults, suggesting girls are more likely to recover. Age of onset also plays a role, with the later onset linked to higher risk of persistence, though findings are mixed. Finally, the longer a child continues stuttering beyond the first 15 months after onset, the lower their likelihood of recovery, although duration may be less predictive in older preschoolers. A study examining a cumulative risk approach found that children with weaker phonological or articulation skills, more frequent stuttering like disfluencies, and lower non-word repetition accuracies are at a higher risk of persistent stuttering. Combining these factors into one model provides the most accurate prediction. Understanding how these factors interact improves our ability to identify children at a high risk and inform early, targeted intervention approaches. Several evidence based interventions exist for working with preschool aged children who stutter. The LITCOM program is a leading direct therapy for preschoolers. It involves parent administered daily feedback on fluent and stuttered speech, with supervision of a speech pathologist. LITCOM program shows the strongest research approach, including randomized control trials and moderate pool effective sizes. We also have indirective approaches such as the demands and capacity model. This model adjusts the child's environment and communication demands to meet their capacities. Research has shown that it can be as effective as LITCOM program in reducing stuttering. Another approach supported for preschoolers is syllable time speech programs such as Westmead and Oakville program. These programs train children to talk with a steady rhythm, make speech smoother and easier. However, the evidence is less comprehensive compared to LITCOM. Research shows both direct and indirect programs can be effective, and in many cases a hybrid approach, combining feedback, environmental changes, and emotional support works best. Key adaptations include early intervention, ideally before the age of 6, parent involvement, so coaching parents to build their confidence and ensure carryover at home, embedding therapy into daily routines like play and shared book reading, and flexible delivery. Telehealth and group programs have also proven to work. As an emerging speech pathologist, our role with preschoolers who stutter is broad and multifaceted. Our key responsibilities start with comprehensive assessment. This includes observations of a child and caregivers' interactions, collecting speech samples in various situations, screening the child's speech, temperament, language, and hearing, taking a detailed family history, including severity rating scale with caregivers. We use our clinical knowledge and consider each child's needs to select the most appropriate evidence-based intervention, such as the LITCOM program. We must ensure interventions align with the family's daily life, mental, and emotional needs. We deliver or supervise these treatments, train parents to implement home based strategies, and monitor outcomes, and adapt interventions over time if progress is limited. At a system level, we advocate for children by educating other healthcare professionals to reduce the inappropriate wait and see approach, coordinating appropriate referrals, and facilitating access through telehealth or group delivery when suitable. Finally, we must uphold our ethical and professional responsibilities. This means documenting our rationale for either treatment or monitoring, providing families with clear, informed consent about uncertainties and expected course, and always ensuring that culture and family context remain the center of our practice. In short, the speech pathologist leads the clinical pathway, conducting robust assessments, communication risks, delivering evidence based interventions, training parents, monitoring outcomes, advocating across systems, and ensuring ethically sound, family centered care. Thank you.